We'll give it another few minutes. Dr. Laskow, I hope it's warmer there than it's going to be here in Chicago. This is when you're glad it's virtual and you didn't actually have to come to Chicago.
I haven't looked at all the numbers, but I'm going to guess that yes, it is a little warmer here, but not a sunny day or not a very warm day.
You want to come to Chicago in September. They invite you for January, just say virtual is fine.
Understood.
A little bit longer and then we'll get started. All right, well, it's 12:03, so that's our start time officially. We're really excited to have Dr. Laskow here with us today, giving us a talk on the association of physical resilience phenotypes with clinical outcomes after total knee replacement, insights from the resilience and total knee replacement study. Dr. Laskow is an assistant professor in the Division of Geriatric Medicine and Gerontology at Johns Hopkins University. His clinical focus is on the care of older adults in the hospital setting. His research focuses on age-related immune remodeling and the characterization of physical resilience among older adults undergoing clinical stressors such as surgery. And with that, I'll let you take it away, Dr. Laskow.
Thank you so much, and thank you again for inviting me. Very happy to be speaking with you today virtually, as you highlight. I suppose if it's very harsh in the Chicago area. I don't have any disclosures. So today's talk, it'll be a little full, but I think that we'll have, good room for questions, which is vital, because really I just want to introduce some key terms in the study of resilience as I and some of my colleagues have been thinking about it, and then really get into kind of the rewards and challenges of when we try to actually adapt those conceptual schemes to a actual specific clinical stressor, such as knee replacement. And then I do then want to kind of evaluate the clinical significance of some of these post-resilience trajectories on kind of more standard outcomes for total knee replacement, and do that by both looking at kind of who has complete recovery and standard outcomes of pain and function after knee replacement, and also among those who don't quite fully recover, what factors affect those groups and how much do they get towards complete recovery. So diving right into resilience, I think it's really worthwhile whenever we discuss resilience to think about what type of resilience, what model are we working on, depending on whether your focus is on cognitive or psychosocial or physical resilience. You might have a very different schema of kind of how this works. Again, just in cognitive, you might have some sort of amyloid burden, and two people have that same load of stress on cognition, but one person is able to maintain and doesn't see or sees a delayed cognitive decline or no cognitive decline. Another person may experience Alzheimer's. And then for physical resilience, that's going to be our focus today. And I'll talk to you about just a few aspects of physical resilience that, as I've been thinking about this and talking to others, have been kind of key aspects of what I think we might be talking about, but I will just say for any of these that there's some very, very insightful person who, could disagree with each or I don't think all of them, but, this is a topic that's being developed. So I think one core aspect of physical resilience as I think about it is that there'd be some type of a stressor that perturbs physiological system, an organism to move away from their baseline phenotype. And then there's a process of recovering back towards, either their baseline phenotype. After a surgery, they might improve beyond that baseline, or, some individuals we know may never quite get back to where they were before that surgery. So this dynamic concept of perturbation and recovery being a key part of physical resilience. Another idea and this is drawing from a literature review by Heather Whitson and others, where from a few years back now, but kind of looking at many different conceptualizations of physical resilience, there tends to be an intuition or idea that this should involve something a little more holistic than like a specific incision, a very specific tissue that's affected by some certain stressor, that this should involve the whole person, whole organism, multiple domains of physiology, the different ways you could break that down. But the idea being that physical resilience should somehow be a little more broader than our traditional specific outcomes that are all, or trajectories of recovery that are all focused just on that. We're talking about knee surgery, so that particular knee surgery or the postoperative pain in the knee. And then this last one, I might seem either too obvious to mention for some, or somewhat beside the point for others, which is that I think of physical resilience as relating to a physical stressor. The idea being that, in the vast majority of instances where we're trying to look at these questions and going back to Resnick et al., kind of defining a psychological measure of resilience, but focused on a physical stressor. This idea that we're usually thinking about some physical stressor, like a surgery, like a procedure, like a specific infection, rather than more psychological things. And I mean, like any category that we name, it's very easy to think of counterexamples. There's fuzzy borders. If you're having sleep deprivation, is that psychological? Is that physical? Both. So, but I think anchoring and kind of thinking and sticking with that is probably a really salient feature of a physical stressor is useful. In terms of conceptual framework, I recognize this is a very busy slide, but I think that I just will come back to this a couple of times and hopefully it becomes a little more familiar. There's this idea that if this was kind of cruciform or cross-like, the more vertical aspect here would be about the person in their kind of baseline state, where there are social circumstances, comorbidities, whatever's going on with their tissues, senescent cell burden, what have you, that's kind of where they are. And there's the functioning of their physiological systems at that moment in terms of their ability to respond, or homeostatic equilibrium or homeostasis. That's the person just as they are at baseline. Then this stressor comes along, a physical stressor, and that leads to a perturbation of that whole person. And then what ensues is this resilience phenotype. So I'm going to say sometimes resilience phenotype or resilience trajectory. The idea is that dynamic period of perturbation and recovery that someone experiences on their trajectory toward getting back to wherever they're going to bounce back to from the surgery, to take Heather Whitson's terminology from Duke. So, and then ultimately resilient outcome, where does the person end up? Why talk about knee replacement? Why was that selected as a domain for the studies that I'll be talking about? Well, one factor is just that it's a very common surgery among older adults, as I'm sure many people here No, just looking at older adults in Medicare. So in 2019, an estimate of 500,000 about knee replacements, and then projected. We all know these projections have their limitations, but that people use for planning and thinking about a procedure as high as close to 1 million procedures in 2035. And then the prevalence, kind of adapting numbers from a 2015 paper, about a little less than 7% of people 60 plus may be living with a knee replacement. So it's common. And by studying the stressor, the good news is that this is, from the few randomized trials we have, from the few, from the many observational studies that have been systematically reviewed, TKR is an effective intervention for most, but there's still between 10 and 30% of people who are still experiencing problems in that knee. And, when you're talking about 500,000 people, the difference between 10% and 30%, I recognize is huge. That variability probably relates to the specific measure, the specific subpopulation, potentially changes through time and how the procedure is done and how we help people recover, but just giving us the best ballpark we have of who still is not completely getting recovered from this procedure. And the notion then being that perhaps understanding resilience, understanding these patterns of recovery and who's at risk for what type of recovery could ultimately help us, before surgery, looking at baseline, or in the course of the time after surgery, kind of looking for signals of people who are not on the trajectory that we'd hope for. And perhaps, that's an opportunity to then target more resources or interventions to help those people reach their best recovery. So I'm going to talk a little bit about prior work, a secondary analysis from the prospective cohort study, the FORCE TJR cohort. But that's not really going to be my focus. I'm going to more kind of use this as an opportunity to, again, think through the challenges, think through how we translate these more general conceptual schema into real world procedures and data. So within this cohort, I'll say Dr. Franklin, who's at Northwestern, is a collaborator on this manuscript and a critical leader for FORCE TJR. It's a very large cohort, and we looked at a subset of 60 plus individuals who are undergoing TKR. And so, again, going with this idea of dimensions of resilience and what can we pull in and what can we capture in this larger cohort setting. So we chose to focus in the spirit of resilience on more global measures. So for those of you not familiar with the SF-36, this is a very widely used measure of quality of life, and it can be broken down to calculate. It has various subdomains, and you can calculate an aggregated score called the physical component summary that reflects kind of an overall dimension of physical well-being. There's also the mental component summary, but I'm not going to be talking about that today, of mental well-being. And then, so we'll be looking at physical component summary, this overall global measure of how someone perceives themselves to be doing physically, and then bodily pain, which again, there's acute pain available in this cohort. So you could look at specific joint-related pain, but we're looking at more general bodily pain in the year after surgery, and then vitality, and gives some sort of a sense of one's energy or perception of their ability to do things, basically what we sometimes commonly call, energy level. And in this large setting, we really had some complete data for baseline and 12 months based on the objectives of the study, the primary study aims. And so what we could look at is more of a resilient outcome. What was the change from baseline to 12 months for each of these more global measures? How did people do after surgery? And, so then we said, okay, resilient versus non-resilient is a binary outcome. And then in order to define resilience and get at some intuitions around that, we said people could either be termed resilient if they improve, meaning that they have an increase in the value for these more global measures of well-being over the course of that 1 year by some threshold I'll get to, or that they just were able to maintain in the upper quartile. So they were doing pretty well for that dimension relative to everyone else, and they continued to do well at a year after their procedure. And how do we define thresholds? Well, for those values for which we had good literature on a clinically meaningful difference when we published the manuscript, we used that. So 5 points for the physical component summary and bodily pain. And then for vitality, we didn't really find a compelling measure of the clinically meaningful difference. So there we just figured out what was the median amount of change that everyone experienced, which was 6 points. Then we took half that value to be our threshold for a significant change. And then we just ask these basic questions. So, well, how common are non-resilient outcomes by these different exploratory global measures, and what demographic factors or social drivers of health might associate with these non-resilient outcomes, just to give us a, kind of sense of the plausibility of what we were looking at. And going back, just touching on this overall schema, to kind of talk about our questions aren't aligned with the main aims of the study. So what we're really able to extract there is this excellent information about the baseline characteristics, and then something about a resilient outcome. How do people end up in their phenotype at the end of that 12-month period? And just because this is not the focus of the talk today, but just because I will talk about factors associated with resilience briefly, I might as well just, say cohort characteristics, more women than men, a little underrepresentation for folks other than people who are white compared to what we know about osteoarthritis, and not many people from other races or ethnic backgrounds. And so then again, at the level of this that I'm going to focus on today, just to talk through, well, what is it comes up when you try to measure resilience or conceptualize that in this cohort setting? How many people were non-resilient? And so we saw for physical component summary and bodily pain, about 15% give or take, and then twice that many for vitality were categorized as non-physically resilient. Of course, we had to make a measure threshold that was slightly different for that than the others, which may have affected that magnitude of difference for vitality. And then just touching on what we found for the associations, again, not going to the details of the odds ratios or so forth, but we saw, some factors that would associate with one, but not all of the measures, and could relate to a range of really not much to say about how marital status, race, or gender would affect the individual categories and not the others. You can think of all sorts of social situations and cultural expectations and other factors that could impact that. And then the factors that consistently, for those who were in that subcategory of individuals who were experiencing non-resilient outcomes by physical component summary, by bodily pain, and for vitality, the factors that were associated with outcomes across all those three measures were age, BMI, comorbidity, and income. So again, some of these you could think about biology, some of these you can think about, access to health and overall care contexts, but at least looked somewhat plausible for comorbidity, for example, being consistent with what our clinical intuition would be for risk for less resilient outcomes. So let's kind of, be real though about what this aspects of physical resilience this may touch on or not. I mean, okay, it's a physical stressor. That's a easy bar. And we, by definition, what we could get at was this idea of a whole more kind of global parameter of a person's phenotype where they perceive themselves to be in relation to a stress, but this is not really a dynamic response, okay? Now, we were looking at resilient outcome, not resilient phenotype or trajectory, but we were doing that definitionally because, the data we really had was baseline in 1 month. TJR, sorry about that, is an extraordinary cohort, in the history of looking at joint replacement, but that's just not what they were set up to evaluate. And so that brings me to what I'll focus on here, which is the SPRING study. And this is a study centered at Johns Hopkins, trying to get at measures of physical resilience, looking at 3 different clinical stressors. There's an arm dedicated to knee replacement, an arm dedicated to bone marrow transplant, and then a pilot arm that looked at folks who were at risk for progressing to hemodialysis. And so today I will really just focus on the knee replacement portion, and there's lots of exciting work and data either ready or in development in different stages of analysis related to molecular and physiological markers that we'll see forthcoming soon. But for right now, I'm going to be, again, really focusing on these these functional measures or outcome measures in this defining of resilience. And very briefly, just an overview of the pattern of the study visits is that we were able to obtain Meredith, the study coordinator, was able, through her excellent work, to obtain these baseline visit evaluations, where, for example, our physical function measures were evaluated, then people have surgery, then they have follow-up for parameters at 1 month, 6 months, and 12 months. And this is where we're getting the data that I'll be discussing. Coming back to our conceptual framework and just kind of identifying where we are in this conceptual scheme and what we're trying to do, and what I'll talk about for the rest of this talk is now trying to get more at this idea of the resilience phenotype. So that pattern of dynamic decline and recovery that we hypothesize is there for patients based on our experience of our patients and family members of, kind of recovering from a surgery. And then looking at some type of more general measures there. And then in this case, we thought that to make clinical meaning of these resilience phenotypes or trajectories, we'd really then want to look at more standard clinical outcomes for the overall pattern. So how do these trajectories predict our classic outcomes by CMS for the evaluation of, joint replacement care, being a measure of pain and function, which I'll get to shortly. So focusing back on that trajectory, on the phenotype, we looked at several measures. And again, I think the guiding principle here to think about is that a little more general than the specific measure. So Pittsburgh Fatigability Scale, not something that has been very much looked at in a surgical context, but has some interesting data associated with outcomes in older adults and other contexts. We had previously looked at like this vitality measure, but there's always the complication of looking at a subdomain when you're using an aggregated score like the physical component summary. So we hypothesized that perhaps this could capture some of these self-perceptions of fatigue and energy, focusing only on the scale has a mental and a physical domain, focusing on the physical fatigue domain. Looking at the short physical performance battery. So this is an objective measure obtained by a trained research coordinator in the study visit. And this is, for those who don't know, this is a very many times applied measure in the context of orthopedic surgery, evaluating lower extremity physical function. And then we did use the KOOS quality of life. Now, I think that it's very fair that you could say, Tom, that sounds a little bit more specific than global in terms of a measure of how people, are doing. The knee is in the name. And I would say that if we were thinking about the peels of an onion, the levels, okay, so perhaps the physical component summary that we've already talked about is very out towards the edge of the onion, and our interest was because this quality of life measure is not used in the CMS comprehensive joint replacement, comprehensive care for joint replacement quality metric, like KOOS pain or KOOS function or KOOS ADL. It's not one of those core measures. And perhaps it could capture something that's knee related, but is a little, think of quality of life perhaps as a step removed from just the brute reality of how function is or how pain is, but kind of how this is affecting you. And also, this is an exploratory stage, so we're interested in having a range of measures, but that's why we included it. And then we've discussed the physical component summary. So these measures would be obtained baseline, 1 month, 6 month. And then we'd use those measures or that phenotype or trajectory pattern to then see how they predict these more specific outcomes for KOOS pain, KOOS function, which are the kind of very standard for the field ways of evaluating knee replacement outcomes. And our hypotheses in this analysis are like very simple and straightforward. We predicted, or we thought based on these models, that the degree of decline that someone experiences would be negatively correlated with resilient outcomes at 12 months for the clinical parameters, and that the degree of recovery in these resilient phenotypes at 6 months would be also associated with, positively correlated with resilient outcomes. And so again, like I'd say that overall theme of the study, we're just kind of going to use regression to ask the most straightforward question about these conceptual schema we have and how they link to a clinical outcome. And in terms of how we did this, so again, we'll look at 2 different models. One is logistic regression, where we're asking, did someone have complete recovery in KOOS ADL or KOOS function, or complete recovery, KOOS pain at 12 months, yes or no? And then the logistic model that includes baseline, delta, the change at 1 month from baseline, and the change at 6 months from baseline. And then covariates that I'll hopefully remember to touch on, or will be on the slide for those results. And then for the general linear model, within a subgroup of individuals who did not see complete recovery after surgery, looking at the factors and using a continuous outcome of how much did they improve towards, and how much did they improve in their pain or function measured by KOOS for their knee. And so a little bit about the cohort, the group of people who participated in this study. Again, we had also in our study more women than men, as we saw in Force TJR. We had a pretty good representation for our Baltimore community of white people, white participants and participants who identified as Black. And then we did not do so well in terms of also recruiting people who identified by other races. And so that limits our breakdown there. And then in terms of comorbidity, I'll highlight just that there weren't so many people who had moderate to severe comorbidity in our cohort, only 17%. And then for physical frailty, which isn't a focus of this discussion, but we did have, at baseline, 19% of people who were categorized as frail by the frailty phenotype. However, it's important to keep in mind that if you're having a knee replacement, you may have slow gait, limited activity. It should be interpreted with caution. Really just looking at how the patterns were of recovery after knee replacement for these, proposed resilience measures. Doesn't need too much comment, but we looked for measures that seemed like they had some change in the period of recovery from surgery. So they all did have some degree of change over time. And it is just worth highlighting here and getting kind of into the stickiness, getting into the challenges of actually translating these concepts is, how much do we think that these patterns of change after surgery match this perturbation and response model, for the physical performance, for the short physical performance battery. Like it's reasonable to see that, perhaps there's a slight dip or a skew downwards for some individual in their performance and then recovery. But for something like the KOOS quality of life, well, a month out from the surgery, people are on a robust trajectory of change. And this could be, related to the fact that we are missing time points earlier in terms of where people were having a harder time, or that, depending on what the specific measure is, how, is a TKR, a stressor that's perturbing people sufficiently, thank goodness if it's not, because our goal is always to, minimize the stress on people. That's a very express goal of the surgical intervention, folks who are improving outcomes. So I'll just talk a little bit about that. Who are these groups of people? So again, so most people saw complete improvement, consistent with that idea that across many studies, total knee replacement is an effective intervention for many, many patients. So that will be our yes complete recovery group. And then our incomplete recovery group is all these folks who experienced some change, but that change did not reach complete recovery. They still had, in this case, some degree of reported pain, and for similar pattern observed for KOOS function or KOOS ADL. All right, so now I'll get into the data here to not have this be tables. I've reported this as the odds ratio per standard deviation. So, think about if someone had, the mean short physical performance battery. This is looking at baseline. So if they had the mean short physical performance battery for every standard deviation that they move in the favorable direction, how do their odds of ending up in that complete recovery group change? And so for baseline, we see, and then again, this is a model that has it's baseline reported here, but the 1 month, 6 month changes are in the model, and then also the covariates, age, gender, race, education, BMI, and anesthesia dose. And so we can see baseline values, basically they all were predictive of how the 12-month KOOS function would look. And I just highlight anesthesia dose here. I won't go over it on all as I flip through the time points, but I'll come back and discuss that a little later for a few of these variables. Anesthesia dose was a significant covariate, and in general, the covariates weren't really coming out with a lot of significance, so I'm not focusing on. So for 1 month change, how did that predict outcomes at 12 months for the KOOS function? And the answer is that they didn't really have a significant association with the odds of experiencing a complete recovery. And for the KOOS function change from baseline to 6 months, that 6-month delta, here we saw that the Pittsburgh Fatigability Scale and the KOOS quality of life, I see that reversed is just referring to the fact that it happens to be the Pittsburgh Fatigability Scale values go in the opposite direction of the other one. So everything looks the same, but the idea is that a more favorable improvement in the Pittsburgh Fatigability Scale or the KOOS quality of life both were predictive, that 6-month change of the 12-month outcome for function. And so, just briefly summarizing, baseline, everything was predictive, but worth highlighting, right, that baseline functional status is not really part of a resilience phenotype, right? I mean, baseline is what we do. Many studies look at baseline parameters like this and others to predict how people will do at 6 months. That's not really the question we're asking. And so of those more dynamic resilience phenotypes or trajectories, it was the fatigue and the KOOS quality of life, knee-related quality of life that were predictive of the 12-month outcome. And then for covariates, I'm going to talk a lot about it, but or circle back to it, I'll just highlight briefly here as an intriguing tidbit. So anesthesia dose, most folks receive propofol, and it was this higher dose of propofol was predictive of improvement in outcomes and function for the KOOS quality of life and the SF 36 physical component summary. And just interesting there, not much, I wouldn't over make much of it, but there is a previous study looking at inhaled anesthesia from a group at Duke, who found that anesthesia resistance, so needing more anesthesia to go under for older adults, was associated with a lower risk of delirium. So I mean, different domain of outcomes, different things, but just kind of an interesting side story as we think about future directions. Okay. Now, a very similar idea, but looking at the 12-month outcome of complete resolution of knee-related pain. Here for baseline measures, only the KOOS quality of life was predictive. And then none of the 1-month deltas. So what we would have thought of as our decline moment, none of those were associated with complete resolution of pain. And then for the change or our recovery time point from baseline to 6 months, it was the KOOS quality of life and the physical component summary that were predictive of having a better complete resolution of pain for individuals 12 months after their surgery. And so again, just summarizing here, what we found of the actual resilience phenotypes we're interested in, it's the KOOS quality of life and the physical component summary. Now I'm going to, let me just make sure I'm doing on time here. So now I'm going to go into the folks who subgroup analysis of people who did not experience a complete improvement in their 12-month outcomes. And just kind of like the most annoying thing that I have done and what I've done working with my analytic colleagues is that the scales are going to be reversed here, where we were looking at the odds ratio before. Now we're going to be looking at a ratio, and because of the use of a gamma distribution and the skew of our data towards small numbers and the gamma distribution wanting right-hand skew, you can even ignore all those words to the degree that I understand them and just know that in the following slides, a value less than 1, a ratio less than 1 is going to be suggestive of people who are having better outcomes, are getting closer to complete recovery. And so that will be the change here. You're going to start seeing lower, less than 1 values, and the lower it is, the more that's predictive of someone being towards a more favorable recovery, getting closer to complete recovery for the general linear models. Okay, that business aside, we'll just do them together and we should have good time for discussion. So looking at baseline, again, not our resilience phenotype, but it's in the model. For KOOS function, all of the patient-reported measures were associated with the 12-month outcome or better improvement in function. And then for KOOS pain, every single one of the resilience measures was predictive of getting closer to complete recovery. For the 1-month change in the trajectory from baseline to 1 month, the delta, only one measure came up, and that was the short physical performance battery for predicting 12-month KOOS function. How close would you get to full recovery and function, even though you didn't reach it? And, just we've all been here looking at the slides, but this is the only factor of the delta 1-month changes that was significantly associated with a standard knee replacement clinical outcome. And then for Coos pain, no factors were associated at 1 month. For the 6-month group, again, the delta 6-month for all of the patient-reported measures to some degree for both Coos pain and Coos function at 12 months were associated with having a better outcome. So the more you experience that recovery at 6 months, the more likely you were in the resilience phenotype measure, the more likely you were to have improvement in the clinical phenotype of, the clinical outcome of Coos ADL or Coos pain in the subgroup. So again, summarized here, a lot of the patient-reported outcomes, both at baseline and at 6 months, and then this one case in which a delta for 1 month decline, quote unquote, as we had conceptualized it, was associated with function. And then focusing just on the things we think of as being resilience trajectory, it was the patient-reported measures at 6 months that were predictive. Okay. So conclusions here. Baseline measures and delta 6-month change trajectory were most reliable, had the most cases in which there was some predictive significance for how people would do at 12 months after their surgery for their standard clinical outcomes of knee pain and knee function. I would just highlight and underscore, I didn't mention it so much as I was talking, but just, it is interesting that if we take baseline as kind of take it for granted, as even if people are measuring all these things in clinic visits, the SF-36 when you go to your orthopedic surgeon, it's still the case that we know and have thought a lot about the baseline characteristics. But adjusting for baseline, there was this significance, this added predictive value to the 6-month trajectory. 1 month, really not so much. So yes, in the subgroup analysis, we did see that what I think is an interesting observation, that this is this case where the objective physical measure of lower extremity performance was predictive, but it's a little hard, right? I think that we're thinking about what to do and how to make the most of that, but it is a little challenging because it's not, you don't really know who's going to be the subgroup of people who have incomplete recovery, who then it makes sense to focus on getting, the SPPB in terms of, being very frank about thinking about ways to move this towards clinical significance, but it's still, notable and something that we're thinking about. And then also just the fact that across all these different time points and periods of change, it really was the patient-reported measures that associated with our outcomes. And although in some cases, if you're thinking specifically about not about baseline, but about the trajectory, the resilience phenotype, really our objective measure of short physical performance battery, not so much predictive of how people would be doing at 12 months for pain and function. These are just some of the limitations, and we can talk about others, but for one thing, we chose as our primary outcome to really consider this resilience to be binary. Did you experience complete improvement or not? It's easy to imagine that there could be people who didn't reach complete improvement who still had very significant improvement that mattered to them, and could very plausibly be considered resilient. I think that this is consistent, even if we don't capture all clinically meaningful difference or so forth, that at the very least, there are ways of evaluating knee function where the evaluation is, are you satisfied with your knee replacement, yes or no? There are other cases in the literature where they look at more of a binary outcome, so it's not totally out of hand. The measurement frequency is something that I I think about a lot in this study in terms of the fundamental conceptual paradigm that we're trying to explore. Is 1 month just a little too far out for capturing people's trajectory of recovery and where their nadir is in terms of function, or where they end up in the early days? We know based on whether people go home or go to rehab, there's so many factors that can, there's a whole world happening between surgery and 1 month that we're not seeing. So that's a limitation, and we don't have so much of a window onto those earlier time points. And then, although this was a huge undertaking and, it was immense to get 100 people in, it's still a small sample size, and some of the, significance thresholds were close or borderline. So perhaps in a larger group of people, we might have seen more signal for some of these in terms of future directions where we are right now. We very much want to connect the whole objective of defining these, resilience phenotypes. One is understanding if they have some sort of a clinical relevance or trajectories, or some time points early post-surgery or in the months after surgery that could actually yield clinically useful information, sure. But we also are interested in linking these to biological measures, things like inflammatory cytokines or immunophenotypes, or many other physiological measures obtained in the spring study. So that's one future area. Also, psychosocial predictors of trajectories and outcomes. I think that there's some, really great work by other groups looking at things like depression and other factors that we don't capture in what we looked at. But you could easily imagine, okay, well, Tom, you said fatigue is associated with outcomes, but what is the association between, fatigability and depression and so forth? And so we definitely need to do more work to explore those dimensions. And then, there are more sophisticated ways to do this that my biostatistical colleagues are leading. Dr. Chen-Li Shui, who is, been pivotal in this analysis and research, is separately as a manuscript under review, looking at latent variable models that kind of follow these trajectories for the same measures, but actually, kind of doing a little more of an unbiased way of picking apart the rich trajectories that people are experiencing as they recover in the year after their knee replacement. And so with that, I'll just give thanks to the spring cohort. Dr. Frederick Sieber and Chen-Li Shui, again, are the lead authors on the manuscript that we're developing out of this work. And then Malik is a biostatistician with the group, and Casey is a fellow in primary care who contributed this manuscript. Meredith down there is our research coordinator who really did all of this work. And then in addition to our Pepper Center, which supports me as a educational awards scholar, I will just also acknowledge the Force TJR cohort team. It wasn't the focus today, but again, Dr. Franklin was really critical in helping us get that manuscript off the ground and completed. So with that, I'm happy to answer any questions and talk about what the heck resilience is. So thank you.
Thank you very much, Dr. Laskow. I am going to open it up to the group for questions. I'm just checking if you need to put in the chat here for us, if you'd like.
And this is the whole, this is the rest of the spring study. It's been a huge undertaking, so a lot of people to thank.
I mean, such an important issue to counsel our patients when they're thinking about, knee replacement or other stressors, who's at risk for a less than, ideal outcome, and what are the things that we can do to intervene on an earlier level to address that. So I think it's such an important issue for so many of our patients. I'm not seeing any questions. Please post them in the chat if you do have questions. I thought it was very interesting when you pointed out about the anesthesia. because usually we think about less anesthesia is better for older adults, right? But you were citing some
Right.
where the more anesthesia actually did better.
Yeah, well, I think that, right. So that's like I mean, there is a little bit of a paradox there in terms of, I think that definitely efforts to reduce, kind of along the same idea that if someone's at risk for delirium, for example, one of the things you could do is, reduce the load of anesthesia they're exposed to. And anesthesiology colleagues, either on this meeting or others, could speak more eloquently to that. But then for these studies, this idea of a measure of anesthesia resistance. So in the case where you're getting loaded with anesthesia, again, the person who's kind of able to maintain consciousness a little bit, that's almost his own mini stressor in a way, a stressor within a stressor, and how you respond.
Yeah, very, very interesting. Okay, well, I think we're gonna let you off easy. I don't see any questions, but I see a lot of people saying thank you.
Yeah, thank you so much.
Oh wait, here's a
Oh.
Is there a way to capture rehabilitation utility in your medical system?
Who went to PT and for how long? So this is a really good question. I was just talking to a colleague in the study yesterday about this. So I believe it's like we did not look at it in this analysis, kind of point number one. But it sounds like actually among all the factors that were collected in this study, there was a time point a little earlier after surgery. So maybe a week or 2 weeks after surgery where they weren't getting the full parameters of someone's, all these, pain function parameters. But they did ask, I believe, about like who went to rehab, for example, versus not. And, in terms of what's better, rehab versus home, where you're moving around and have, compelled to do things. I generally counseling, unless you have a really specific medical management need, I'd say, better at home. But so there. And then in terms of the volume or amount of PT and when it stopped, beyond the question of disposition from their knee replacement, I don't know if we have it, but it's a good question to try to figure out. Prehabilitation. Yeah, prehabilitation. I'd be interested, whoever asked the question, I'd be interested to pick your thoughts about that. Because in general, I think it's a great idea. The studies that I've seen, and there could always be something more that it comes out than what there's always a new study, but I have not seen things that were so compelling to me that it's like having the full effect that I have, although there's certainly individuals, like a frail individual, many people who I certainly would recommend prehab to, just kind of on a pragmatic grounds. And so are we thinking about that in our analysis? I don't know what, so I've been so caught. The aim here is to get to the next study and to figure out the next thing to look at. It feels so much like our immediate questions are about correlating these phenotypes with the, biology or clinical and social context. But short answer is that prehab is a great example of the type of intervention you could look at. I think that this specifically what we're asking with these resilience trajectories, right? I think it's worth being upfront about the fact that the real rationale clinically, I think, would actually be changes or modifications to physical therapy after the surgery, right? Because we're not going to get a resilience trajectory before the procedure happens. So the question would be, is there any signal we can pick up in who we might be able to support to do better? I think that's a concept that's, even less tested than, rehab, which we do have a number of studies about, but that's probably for specifically the concept of a resilience trajectory, more what we could do, if that makes sense.
All right, well, thank you very much. And thank you everyone for joining us today. Hope to see you next month at our next pepper rounds. And thanks again, Dr. Laskow.
Thank you so much again for inviting me. Take care.
Have a good day, everyone. Stay warm.